welcome to the FlightBridgeED Podcast series.
Hey everybody, Eric Bauer back with you. Well, I just want to welcome everybody to January 2015. We did have a great year last year. The last 6 months didn't put out as many podcasts as I would hope, but obviously, this is a new year. I was very, very busy with not only my primary job, but travel and work, and then building this house. So that project is just about completed, and I can get back on a normal schedule. I've got a great list of podcasts that we're going to do over the next 2 or 3 months, some really good topics. We're going to start off today with a kind of a new concept that I've really had to think about and study and really contemplate over the last couple of months. And it's regarding ventilator strategy. And as everybody knows, that's kind of my passion. That's something that I really strive to be an expert in our field over, and I'm constantly trying to learn new concepts and new things. As everybody knows, I do work for Air Methods Corporation, and we're always trying to lead the way in different avenues, protocols, and things like that. And we've got some great medical directors, and we've got a scientific advisor named Dan Davis, and he does a lot of research and a lot of cutting edge things, not only in the HIMSS industry, air medical, but also in the critical care environment around the world, in specifically airway management. And based on his research, he's actually come up with a concept related to our hypotensive trauma patients and how we deal with them on the ventilator. Again, when I first read the protocol and when I first read the rationale on why we do this, I was a little bit taken back, because all of our strategy over the last few years, specifically based on the ARGNet studies that have been published, has been lung protective strategy and how we deal with our trauma patients, our pulmonary edema patients, our COPD patients, our lung disease patients, and to lower the incidence of ventilator lung injury and ARDS. So when I read this protocol, I was a little bit, again, taken back by it, and I had to kind of sit back and think objectively and not jump to conclusions. But after reading the rationale and really thinking about it, it actually makes a lot of sense. So this podcast is going to be probably 15, 20 minutes, and we're going to just jump into the pathophysiology, jump into the protocol. Again, this is something I just want everybody to think about. I want you to think about the pathophysiology and why a company the size of Air Methods has actually employed a protocol this cutting edge. So the protocol is this. On any hypotensive trauma patient, and we'll say a systolic less than 80, we know that to maintain good perfusion to our brain, good perfusion to our kidneys, we have to maintain a MAP pressure of 65. If we drop below 60, actually specifically in the 50 range, we actually really lose perfusion to our brain, and that's where we start seeing adverse effects. The same goes for our kidneys. If we stop perfusing our kidneys below a MAP of 60, our kidneys actually think that we're in trouble, and it's going to decrease or stop urine output, and it's going to stop or slow perfusion to the kidneys. So it's very imperative that we maintain a MAP pressure of 65 in all of our patients. So the whole point of managing our patients in trauma now has led to a permissive hypotension kind of rationale and approach, where we don't give a lot of volume, we don't give a lot of fluids, normal saline, we don't raise that blood pressure up into the above 100 systolic like we used to, because we've learned that, number one, normal saline is a very acidotic fluid, and when we give copious amounts of volume, we actually start down this inflammatory cascade. We can actually initiate DIC and other issues. On top of that, we're actually raising our MAP pressure up excessively high, and if we have blunt force or penetrating trauma to our large organs like our liver and our spleen, and we raise that pressure up, we're actually going to cause more bleeding. It's kind of the rationale of grabbing a bottle of water that's half full and poking a few holes in it, and if we start squeezing that with our hands, what's going to happen to all that water? It's going to pour out. Well, that's exactly what we were doing to our trauma patients that had hemorrhage, internal hemorrhage. So the whole rationale now is to maintain a blood pressure that gives us a MAP of 65. One of the obstacles that we have is if we have a patient that has significant blunt force or penetrative trauma and they're bleeding out and they have airway issues, we have to provide advanced airway management and we place them on the ventilator. Well, based on the lung protective strategies that we've employed, based on those ARDS-NET protocols and studies, we've gone to a lung protective tidal volume that's more physiologic and a higher respiratory rate. Well, if you've listened to my podcast, I'm a big advocate on protecting our patients with lung protective strategy and understanding the concepts of dead space. Well, when we ventilate our patients, we automatically have dead space. We have dead space anatomically, and we have dead space actually in our ventilator circuit, in our ET tube, and things like that. And for a normal, healthy adult, we lose approximately 150 mils per breath. So this is where we come to this protocol. This protocol is based on a high tidal volume of 10 to 12 mils per kilo. So think about that. If we have a 100 kilogram patient, we need to be ventilating them at 1,000 to 1,200 mils per breath. So that right there is what rattled me, is that huge tidal volume. That's how we used to do it back 20 years ago, or I should say that's how they used to do it back 20 years ago, where they employed these massive tidal volumes and they were causing barrel trauma, they were causing high plateau pressures, ventilator lung injury, and ARDS. And that's the whole purpose of the ARDS-NET group, was to test those theories, and that's where they came up with those lung protective strategies. But if you think of why the research is showing to do this, I think you'll kind of sit back and think about it and you go, well, that kind of makes sense. So like I said, the protocol is a tidal volume of 10 to 12 mils per kilo. And instead of that higher respiratory rate, and what I mean by higher is you've heard the podcast, and when we do our injury approach, we need to have a respiratory rate between 16 and 18 to give the minute ventilation that's required to provide for that loss in dead space. Well, with this protocol, we're giving that tidal volume range of 10 to 12 mils per kilo, but we're only ventilating our patients 6 times a minute. And here's why. When we breathe for our patients in that lung protective approach at 18 times a minute, and I'm just using a number, every time we ventilate that patient, we lose volume in dead space. So if you haven't heard my podcast on that, just really quickly, what I mean by that is if we provide a 500 tidal volume, which is very physiologic, it's a very safe tidal volume, based on dead space and what we lose on a normal adult, you're actually only getting 350 mils to our alveoli. So that's currently the meaning of alveolar minute ventilation. So we lose that volume, and that volume ends up in our chest, it ends up elsewhere. So if we're ventilating our patients at 18 times a minute and we're losing all that to dead space, what we're actually doing is increasing interthoracic pressure. That may not be an issue for a normal intensive patient that's not hemodynamically compromised. But when we're talking about a trauma patient that's hemorrhaging, that's hypotensive, and again, when we look at a systolic less than 80, then that's a big deal. That interthoracic pressure that's built up based on that higher rate and that dead space loss that's causing that interthoracic pressure can really impede vascular tone, and it can press down on those vessels, and it's not going to allow for an optimal blood pressure, and that's going to translate to a low MAP pressure. And I just explained that we have to have a MAP pressure of 65. We have to have a MAP pressure of 65 to perfuse our brains adequately and perfuse our kidneys. And remember, just in normal homeostasis, cardiac output, 25% or so goes to our kidneys, and another 25% goes to our brain. So just half of our cardiac output alone goes to those two primary organs. So if you think about ventilating our patients at 10 to 12 mils per kilo, that's a huge volume. So here's a few terms I want to explain. The first one is called a lower inflection point, and the next one is called an upper inflection point. So a lower inflection point means that this is the minimal amount of volume needed to maintain alveolar recruitment. And we know that alveolar recruitment, or our intrinsic PEEP, is secondary to nitrogen that hasn't diffused out of our alveoli once we bring in atmospheric air. If we're bringing in atmospheric air, remember, we're not just bringing in oxygen, we're actually bringing in nitrogen, which is our dominant gas, which is 78% of atmospheric air. And nitrogen is a very dense gas, and it doesn't diffuse very easily. It takes a lot of pressure to diffuse nitrogen. So once those oxygen molecules diffuse through the alveolar capillary membrane, we have nitrogen that's left in the alveoli, and that nitrogen actually causes a pillow or intrinsic PEEP. So the minimal amount of volume needed to maintain alveolar recruitment is what's called that lower inflection point. In contrast, the upper inflection point is related to how much volume maximum we can actually deliver to not cause barotrauma or overdistension of those alveoli. And it'll surprise you in the amount. It surprised me. So in a normal lung, we can provide 1.5 to 2 liters of tidal volume to these patients. Now, this isn't going to be long term, but in the acute setting, we can provide that large of a tidal volume for those patients. So that's considered the upper inflection point. So based on that, they looked at this research and they performed studies, and they came up with 10 to 12 mils per kilo with a lower respiratory rate. And if you calculate that out based on a minute ventilation, you're going to be about the exact same minute ventilation as we would using a lower tidal volume and a higher rate. We're just actually now delivering that in a different manner. But instead of building up that interthoracic pressure and building up the dead space, we're actually lowering the interthoracic pressure and limiting dead space by the frequency that we're delivering that tidal volume. Another way to explain this is if you were providing care in the EMS or hospital setting 15 years ago, and you remember BLS procedures, we provided 5 compressions for every 1 or 2 breaths. And as time has went on, AHA has done research and realized what we were doing is every time we did our 5 compressions and stopped, we never allowed that pressure to build up to optimize blood flow to the heart. And we would stop and we would give a ventilation. Well, that's exactly what we're doing here with this hypotensive approach, is we're giving a big volume, but we're limiting that volume to 6 times a minute. So we're allowing that interthoracic pressure to be very limited. So AHA looked at that and they said, you know what, we're not providing a good pressure, we're not providing good blood flow. And so they've increased that now to our 30 compressions, and then we ventilate our patients. And so you can imagine if you drew that out, how much pressure we're actually building up. And by the time we give our breaths and we start compressions again, that pressure hasn't dropped back down. Well, that's exactly what we're doing in the lung protective strategy for our patients, is we're actually building that interthoracic pressure up. We're losing all that volume to dead space that's building up, and that's causing an impedance on our vascular tone, which is hindering our blood pressure. Now, the important thing to understand is that when we look at lung protective strategy, the whole purpose of lung protective strategy was to lower the incidence of ventilator lung injury and ARDS. So a lot of our ventilator recommendations are based on those ARDSNet protocols and studies. When you look at a sick lung like an ARDS, the upper inflection point, remember that's the maximum amount of volume that we can give to not cause overdistension, is actually around 1 liter. So it's a lot lower than a normal healthy lung. So when we look at lung protective strategy and you look at what's going on with those patients, they're in a severe oxygenation failure. So in that setting, it's much better to actually increase interthoracic pressure and cause that dead space loss than to limit oxygenation. So for ARDS patients, it's still very important, even if they're very severely septic and hypotensive, it's still more important to have that interthoracic pressure and that dead space loss than to limit that and provide poor oxygenation for our patients. Because remember, we can always, in those patients, provide inotropy and chronotropy with our vasopressors, adding norepinephrine and dobutamine once our pressure comes up. So this strategy is just for our hypotensive trauma patients only. So again, tidal volume of 10 to 12 mils per kilo, a frequency of 6 per minute. That limits that interthoracic pressure. It limits the dead space loss. And this is for our hypotensive trauma patients. All right, the next aspect of the protocol is if you think about how we bag our patients, when we bag our patients, number one, just intrinsically, we bag our patients too fast. But when you bag your patients correctly, you're actually squeezing that bag for 2 to 3 seconds at a time, if you really think about it. And if we squeeze the bag for 2 to 3 seconds at a time, that's very, very similar to giving these breaths for long periods of time, and it actually, again, increases interthoracic pressure, and you lose some volume and dead space. So based on that, we need to set our I time at 1 second. And so based on whatever ventilator that you're using, whether it's an LTV 1200 or the Ravel ventilator, I'm just naming a couple, you would need to override the ID ratio. Once you set that rate at 6 and you set that tidal volume that high, that ventilator is automatically going to go to an ID ratio that's very lengthened. It's going to probably go to like a 1 to 6 or 1 to 7. So you need to override that and actually go to the I time and switch that back to 1 second, 1.0. And what that's going to do is that's going to actually limit the inspiration time, and by limiting that inspiration time, you're going to limit the pressure. The last thing regarding this is you've heard me a lot talk about oxygenation and optimizing oxygenation. The best way is to provide the minimal amount of FiO2 because of the potential for oxygen toxicity and absorptive atelectasis, but optimizing oxygenation by providing good, adequate PEEP. So the other aspect, or the last aspect of this protocol, is if you have a patient that's hypotensive like that, again, systolic below 80, and you've employed this protocol, you need to turn your PEEP off. So let's talk about that. Again, PEEP, any type of PEEP is going to cause interthoracic pressure. That's the whole point. Remember, PEEP maintains alveolar recruitment. Your inspiratory maneuver, your actual tidal volume that's delivered, recruits the alveoli, but that PEEP maintains that recruitment, keeps that lung inflated based on that pressure that you've set. So in this protocol only, you're going to employ the 10 to 12 mils per kilo. You're going to set a frequency of 6. You're going to set an I time of 1 second. And then lastly, you're going to turn the PEEP off to 0. And that's basically this protocol. So I just wanted to kind of lay this out. This is a very new concept. I'm sure there's going to be a lot of people out there that are going to kind of scratch their heads like I did. But I think the longer I've looked at this, I've taught on this, I've read on it, it actually makes a lot of sense. So I encourage you to email me. Remember, my email is eric.bauer@flightbridgeed.com, or give me a call. If you have my email address, you send me an email. My phone number is at the bottom. And I'd love to hear your thoughts or any experiences you may have. If you have any case studies, really cool cases that are kind of off the wall or pretty complex, I'd love to present these in a podcast. We do the Nightmare series, and that Nightmare series has become very, very popular. And lastly, I want to thank everybody for the last 2 years. It's been the most rewarding thing I've done in my career, and I love hearing the great emails. I love knowing that we're providing good education, and we're always trying to better our products and things like that. We've actually hit a milestone. We're up to over 400,000 downloads, and we have listeners now in over 30 countries, and that's a testament to our listeners and word of mouth and things like that. So on behalf of all of us at FlightBridgeED, I just want to thank you again, and we'll talk to you soon.
We want to thank you for following FlightBridgeED.